GEMS was registered on the 1st of January 2005 with the purpose of ensuring adequate provision of quality healthcare coverage to public servants that is efficient, cost-effective, equitable, and provides further options for those who wish to purchase more extensive cover. We're currently South Africa's largest restricted medical scheme with over 800,000 principal members and 2 million beneficiaries. We offer 6 excellent healthcare benefit options, namely Tanzanite 1, Beryl, Ruby, Emerald Value, Emerald, and Onyx. Tanzanite 1 option is our entry-level network benefit option tailored for level 1 to 5 employees and is subject to network GP nomination and specialist referral rules. Beryl is also an entry-level network benefit option tailored for members with limited healthcare needs. The Ruby option is a mid-level benefit option tailored for members with limited to average healthcare needs. Ruby members also enjoy a personal medical savings account. Emerald is a high-level traditional option tailored for members with average to above average healthcare needs. The Emerald Value option is our efficiency discounted option of the Emerald option, tailored for members with average to above average healthcare needs. Onyx, which is our top-level benefit option, tailored for members with above average to extensive healthcare needs. Our goal is to provide public service employees and their families with quality healthcare services at the most affordable rates. The brilliance of GEMS is demonstrated in our efficiencies to improve the overall experience for each of our members. An average of 2.9 claims are processed per second, an average of 72 registered babies per day, and we admit 0.8 members per minute per day to the scheme. GEMS truly understands the South African family and its needs. Some of our members who have discovered the brilliance of GEMS also shared their sentiments. Join us and discover the brilliance of GEMS. GEMS is an authorized financial services provider.
Good afternoon, everyone. I hope that everyone is doing well this afternoon. I do trust that I am visible and audible. Colleagues, my name is Zandile Mdleje, and I am a Provider Relations Manager for GEMS, and I will be your facilitator for this afternoon's engagement. I'd like to welcome you all to our very first Occupational Therapist webinar. I see we have quite a good attendance. Colleagues, please do feel welcome. We are very grateful and appreciative for your time that you've taken this afternoon to come and engage with us as the scheme. In terms of our agenda for this afternoon, the session is scheduled for 2 hours. And we will start with a welcome address from Mr. Ramuelo Ditwane. And then we have some presentations that we have prepared for you. The first one will be from our managed care organization covering managed care processes. And then we also have a presentation from our administrator, which will look at the claims overview as well as key insights from a claims point of view. Then we have dedicated colleagues an hour for a question and answer session because we would love to hear from you so that we are able to address any issues or questions that you might have. With me in attendance this afternoon, I have a lot of colleagues that are dialed in from the scheme as well as managed care organization as well as claims administrator. So throughout the presentations, if you have any questions, I'd like to please request you to capture your question in the Q&A box, not in the chat box, please in the Q&A, so that then my colleagues that are also online can attend to your questions and answer them. And then later on in the last hour that we've scheduled for Q&A, we will take hands. So if you've got a question that you'd like to raise, you can then raise in that session. We'll also go through some of the questions in the Q&A box that would have not been responded to at that stage. But just in terms of housekeeping in general, please feel safe to engage with us. As the scheme, we have a principle of psychological safety in our meetings. So I'd like to also encourage you to feel psychologically safe. We do encourage open, honest, as well as active participation. The only request that we have is that we please do it in a respectable and professional manner. So I will go straight to then our first agenda item, which is an address by Mr. Ramuelo Detswane. So thank you. So just to introduce Mr. Ramuelo Detswane, he's the Senior Manager for Healthcare Networks and Provider Relations for the scheme. He's a seasoned healthcare professional with over 25 years of diverse experience across public and private healthcare. He joined James in 2019 and is currently the Senior Manager responsible for Healthcare Networks and Provider Relations. His portfolio involves hospital, healthcare providers, and the James Provider Liaison function. Over to you, Mr. Ramuelo.
Thank you, Zandile. Good afternoon, colleagues. I trust you are all well. Yes, from our side, we really appreciate you taking this time to join us on this first webinar that we are hosting as the scheme to engage with occupational therapists. As the scheme, we pride ourselves with an open door policy, and this open door policy is influenced by one of our strategic objectives that informs us to be an organization that is effective in its communication with its key stakeholders. Now, you yourselves, as our valued practitioners, we really want to take this opportunity to have a robust discussion with yourselves in this afternoon, because from James, we don't hide behind emails. I always use this a lot with most of our providers. We don't hide behind emails or contact centers. And where it is necessary to engage in person, we do so, and we do these engagements at all levels, from a society level. In the case of occupational therapy, we do meet from time to time with OTASA, and how we engage with them. We have what we call strategic engagements that we do twice per year, where we look at various strategic matters. And then we also have what we call operational engagements, where we look at day-to-day matters, operational matters that as members of these organizations or associations, you report back to them, and then they then give that information through us at the scheme. But we also have such kind of engagement similar to what we are having today, where we go out into the provinces where we engage everyone face to face. That one, we call it the provider summits. We've had 2 this year. We had one in Cape Town in Feb, and then it was followed by another one in Limpopo. And we will be going to the Eastern Cape in August, and then we'll conclude the year in September in the Free State. And these engagements really give us some valuable insights as the scheme. As we have picked up, there are challenges with some of our operational processes, some of the benefits, some of the options that we have, the benefit designs, and the challenges that providers are facing. We are then able to use these engagements and gather that information, and then we bring that back into the organization to amend and correct where we may need to correct. And I always say through these engagements, we will often agree on certain things. At the same time, there are areas where we will not agree. And then we have to now also agree to disagree. And I always say, so is life. We will never always agree on everything. But for this afternoon, we really want to address a lot of some of the challenges that you as our valued stakeholders have been experiencing with our services. And we trust that with your honest inputs, we will really be guided. And we really want to plead with everyone, engage us, direct us. Where we are wrong, we will admit and we'll correct ourselves. and we'll also want to highlight some of the concerns that we are also seeing in our environment. So this is more of a mutual relationship that we want to establish with yourselves. And I can assure you, this is not only going to be the first time that we will be having such a session with yourselves. Now, a new development that is going to happen from 1st of July is that the scheme, through its provider liaison office function, will also be rolling out engagements into the practices through our PLOs. Throughout the 9 provinces, GEMS has opened offices that are very specific to supporting healthcare providers. So please do welcome them when they come. It's all about building those relationships that we all need. They are not there to spy on you, they are not there to audit on you, but they are just coming to build that relationship and assisting you where you can. And one other innovative idea that we are putting together as the scheme is to put together an upskilling program where we will be assisting all our healthcare practitioners with some of the day-to-day challenges that you may be having, either related to coding or related to some of our internal processes, some of the other challenges that are out there in the industry, such as fraud, waste, abuse, as well as error. So the scheme is now taking that proactive attitude or stance to also support the practices, even at your individual practices. So please allow them to come through when they call to make appointments and to assist where they can. We are also all available. You will always be able to reach us at any given time. With that being said, I also want to say thank you, Zandi. I'll hand back over to you. And colleagues, you are all welcome. And I trust this will be a very fruitful discussion for this evening. Thank you.
Thank you, Mr. Ditswane, for that address. That was our senior manager for provider relations within the scheme. So we are going to move on, colleagues, to the next agenda item that we have for this afternoon. And we have a presentation from our managed care organization. We will first hear from Dr. Ziyanda Makaba. Dr. Ziyanda is a pediatrician specialist who is currently leading the provider network and contracting portfolio in the James Fund Management Unit at Med Scheme. She oversees strategy and execution in managed care across provider engagement and health risk management, with core focus areas including network contracting and optimization with system level performance. Dr. Ziyanda, I'm handing over to you. Please proceed. I'm sorry, before you do, Dr. Ziyanda. So colleagues, while Dr. Ziyanda is presenting, if you have some questions, you can either jot them down for later on, or as requested, you can put them in our Q&A box, but we will not be taking any questions in terms of hands until we've completed all the presentations. Thank you.
Thank you, Zandi. Good afternoon, colleagues. As Zandi has mentioned, I'm from the Managed Care organization, and I will be then speaking to the managed care utilization, as well as giving a bit of a background. Then I will hand over to my colleague Itu, who will take you through the managed care processes. All right, so what this, I think, just to say the context of our engagement or webinar today is, to just address some of the core utilization issues that we've seen, and then also to just discuss and align on clinical governance operational issues, as well as any clinical requirements that we may have. Over time, GEMS has noticed an increase in terms of occupational therapy-related expenditure and utilization, specifically, I think, in the inpatient utilization. And these emerging patterns involved like high utilization, high frequency of sessions, and diagnostic codings, and some issues and consistency issues there. So I think in response to that, which we'll cover later on in our presentation, we then did put some managed care controls to make sure that the pre-auth processes and case management go smoothly to address some of the utilization issues that we were seeing. And then obviously the measures were there to make sure that we are aligned by we managed care organization, the scheme, as well as the providers on what services are being rendered and clinical appropriateness of it all. And I think some of the concerns and the clarity that the providers I need in this process, this is a platform for us to be able to discuss those and align so that the process is seamless. I think the bottom line is that the key objective is that we want to make sure that the provider experience, the service that we provide are clinically appropriate and it benefits our members who are your patients. And then at the center of it all, or the core of it all, is that we must have a system that is sustainable. So I think if we were to look at overall, like the intention is to make sure that we have clinically appropriate services, we are funding what is needed, and we are doing this in a sustainable environment that benefits our members. As a summary of today, it's meant to create a practical alignment between you as a provider, with your clinical judgment and our members, what outcomes they get and how efficient the process is. So we have to do this collaboratively because one person alone is not able to do it. We, as GEMS is the scheme, we do fund appropriate clinical care, but we need healthcare providers to then provide those services. Our members are also the ones that are receiving these services, and we are guided by academics as well as professional bodies in what we do as professionals as well as a scheme, and then all of that is happening within facilities. So we are an ecosystem that needs each other, and I think Billy put it well to say this is a good platform for us to collaborate and advise what works and what is not working and why some things are there. Hopefully we will agree more than we disagree. So I think that is the whole purpose of the webinar, to just strengthen that alignment and make sure that the clinically appropriate services are received by our members, and that we create this platform, and hopefully we'll have more of this platform. And then where there are some inconsistencies and some clinical governance gaps, so we can close those as well. I think that leads well into my next slide, which looks at, in terms of clinical governance, what we're looking at is, sorry, is making sure that we have the member in our mind in terms of the member must get the services that they actually need. And then this must happen under clinically appropriate or clinical governance services, and making sure that the system is not going to collapse through, higher services being rendered than needed, and that makes sure that we operate in a sustainable manner to keep the system integrity intact. So what I want to share is that the objective is not to say when a patient needs care, we don't give the care. So we're not reducing necessary care. We want to ensure that the healthcare that we do deliver is clinically appropriate. It is coordinated, it is sustainable, and it is aligned to the best practices that we have out there. All right, then looking at the next couple of slides, I will be sharing our utilization, more specifically for occupational therapy. So we'll look at utilization over the last few years and sort of discuss, what we have been seeing as trends. So if you look at this graph that we have over here, on the left-hand side, we've got a graph that looks at the authorizations requested by OTs for GEMS members from 2023 to 2025. And then in the yellow, we have the number of sessions aligned to that. So we can see that if we look at year on year, we've seen a marginal increase in terms of our authorizations from 2020 to 2024. And we've also seen a rise in sessions between 2023 to 2024, and there was a decline in sessions requested then. I think this is part of the managed care processes we put in place, so that we only focus on sessions that are clinically relevant. If we were to compare the growth in terms of the GEMS membership, we have seen a growth of about 5% from 2022 to 2024, and a growth of 2.5% from 2024 to 2025. Sorry, this is 2025. My mistake over there. So if we could to compare the year-on-year growth between the GEMS membership and the utilization when it comes to authorization and sessions. So for authorizations, there's initially 20% increase, and then 11% increase with an overall 34%, whereas there was some decline there. We can see when there was an increase, it was not necessarily related to the membership growth in GEM. So it was out of keeping. Yes, there may be other factors that we need to obviously factor in terms of the underlying diseases and need for services. But it's just to better understand some of the utilization and aligned with our membership. Then in this slide, we're looking at the number of OTs that are specifically requesting GEMS authorization over the years. And we've seen an increase of OTs requesting GEMS services of about 36% from 2023 to 2025. And if we look across the provinces, there has been mostly an increase. Some provinces this year a drop. So Gauteng, KZN, Western Cape, and Free State saw an increase, a rise in occupational therapists over the period of 2024 to 2025. Just to contextualize that some of the utilization will be increased appropriately to the increased membership, increased providers available or servicing our GEMS members, sorry. Then this slide then is contextualizing some of the utilization trends that we see. So if you look on the left side, where it's looking at our provincial breakdown of our utilization between 2024 in blue and 2025 in orange. And in the lines of the graph there, you see the session authorizations. So it's the number of sessions per auth that was requested for both years, each color matching with the relevant year. So if we look across the provinces, Free State, Gauteng, and KZN have high utilization, and that utilization is in terms of them being higher. We know that they are heavier or higher provinces, and we did say that they have higher presence of occupational therapy. But what we see in terms of the average sessions required per auth, we were seeing that in 2024 we had quite a high number of sessions, averaging around 11 or 12 sessions for each auth, and that has subsequently declined, averaging around 7 to 8 sessions in 2025. Then when you look at a month-on-month basis, we're comparing 2024 to 2025 again. In the bold lines, we're seeing the number of sessions for that year. So green still being 2024 and orange being 2025. We are seeing then the number of authorization in the dotted lines. So bold is sessions, dotted lines is authorizations. So and in terms of the sessions, we are seeing that there's quite a high number because the sessions are in the tens of thousands, while the authorizations are in the thousands. So we're seeing that initially, if you look in 2024, we had, which is in blue, we had quite a high number of sessions at the beginning of the year that only tapered towards the last quarter of 2024, including the high number of authorizations compared to 2025 as well. But then we saw with 2025 a drop in the number of sessions as we were implementing some of the managed care processes, asking for clinically appropriate reasons for services being rendered. Right, then if we looked at the previous slide here, we are seeing Free State being very high in terms of utilization, even higher than Gauteng, compared to the number of OTs that we have in that province. So we decided to look at maybe per 1,000 lives, those sessions could be maybe lower, but maybe because maybe there's higher membership there. But we are seeing that Free State is still quite an outlier province when it comes to authorization request by OTs, where we are seeing very high number of sessions and authorizations in 2024 and 2025 phase. There was a drop in 2025, but it's still out of keeping for the population there. So it's something that we could discuss to say what exactly is happening in Free State versus what we expect or what is the norm in the related provinces. My next slide is then looking at outlier providers by anonymized by provider 1 to 20 and the provinces, as well as the utilization over the last 3 years. So we're seeing a quite high number of sessions requested by some providers, and this is not the average. This is quite outside of the average when we look at it. And you have some providers on the excess of having like 15 sessions per authorization. So what we want to understand here is these high session volumes and the concentration among certain practices. How do we then know what is clinically relevant? And in terms of the utilization intensity, is it still something that is clinically aligned? Or is it, a matter of services that are necessary or evidence-based services? Then on the last slide, just before I hand over to my colleague, I'm looking at of the 20 providers, we selected the first 10. So whoever was provider 1 is 1 that side, 5 is 5 that side. Just to look at the sessions that we have, we just selected out 2024 because that had the highest utilization prior to some of the managed care processes that were implemented. So if you look at, let's just take, for example, the first provider sessions that requested in that year, and per member, when we're looking at the average sessions per month as well, and then looking at if those sessions were broken down into the working day, that would mean that there'll be 24-hour session, 24 sessions per work day, which sometimes we need to then ask ourselves what would be plausible there or not, or whether this practice is a group practice or not. But these practices are registered as practice, solo practice. So they were not under the practices registered for group practices. So we need to obviously better understand from interaction with the providers of what is happening there. Is it registered correctly? Is the management as what is needed? Is the evidence-based care? How will sustainability be affected by the utilization intensity? And I think that goes to say with the rest of the providers in the slide, but just wanted to make an example there. I'll pause here and then I'll hand over to my colleague Itumeleng, and then I'll just cover the last 2 slides when she's done. Thank you.
Thank you, Dr. Ziyanda Magaba, for that presentation. And as Dr. Magaba has indicated, we are going to hand over to Itumeleng to continue with the presentation for the managed care organization, now focusing more on the actual operational processes. So Itumeleng Sidiba is a healthcare fund manager with over a decade of experience in managed care, specializing in healthcare funding, benefits management, and sustainable healthcare solutions. Going to hand over to Itumeleng, please proceed.
Thanks, Sandy. Good afternoon, everyone. Thank you so much for this opportunity. So as Dr. Ziyanda has mentioned, and Sandy, I will be taking you through the changes and the journey that we've taken as to where we are and how long it's taken us to be here. I think it's important for us to note that we cannot speak about the current 2026 process without speaking about the history. So in terms of where we have been, so around 2016, the scheme went through like a cost blowout. What we were seeing is that we had a lot of providers, especially allied health providers, that were getting your hospital stickers and they would claim, but they were not necessarily referred by the treating provider. So back in 2016, we then implemented a process where we said we would require an actual referral letter from the treating provider in order for us to be able to look at that particular case. Thereafter, this was actually a retrospective process that was put in place. So after the fact, then that would be the requirement. As we went along to 2024, we started then looking at how we can improve our process. And with that, we then started implementing a prospective process. So in terms of the prospective process, so meaning while patient is admitted into hospital, we are able to get that information from the DSM form, or especially in instances where it's a rehab or subacute case, because we normally get those reports upfront and they're quite comprehensive. So then in 2025, while we were busy with the enhancements, we also noted the trend that Dr. Ziyanda spoke about earlier, where there was just an upward trend in terms of the number of authorizations and the number of visits that we started seeing in terms of hospital admissions. And what that started telling us is that perhaps we don't have a real understanding of exactly what is happening, because we would get to a point where if a patient is admitted, for example, in a mental health facility, for 21 days, we started seeing that our allied health providers are seeing that particular patient for 21 days. And there's providers that are actually seeing the member. And we then started noting that this obviously would then become a problem. So therefore, in 2025, a process was implemented where we put 2026, we put just a bit more controls, and we started educating our providers. And this is why we are actually doing this drive as we go along, so we can make sure that we do educate along the journey, and we take you along the journey with us as healthcare providers. If you can go to the next slide, please. So the next two slides really just speak about our process and how it really plays along. So we speak about a prospective process and a retrospective process. And I really just wanted to take time just to take you through it. So our prospective process is while patient is in hospital. So this is during the admission itself. So then what you would then do as a healthcare provider is submit your referral letter to hospitalauths@james.gov.za, and you would then request an authorization from us. And what we would then do is that we will provide you with an authorization for a default length of stay. And in order for us to then update that particular case for more days, then what we would require is a daily progress report. So a lot of providers become very confused when I start speaking about a daily progress report. It is really, we want to understand what you did that patient on a particular day. As we mentioned, a lot of the time we see that our patients are seeing 3 or 4 providers for individual sessions, let's say, for example, in a mental health facility, plus they're having quite a few group sessions on the same day. So in order for us to just have an understanding as to what is happening, and this is why we need those progress reports, we want to understand what is it or what is happening from a hospital facility perspective, because we are not physically there and we need an understanding as to the treatment that's been rendered to our patients. So once you have submitted all this information, it will go to our site case managers or our different case managers. They would then make a funding decision. And generally, the email address for hospital auths is 48 to 72 hours, because this would happen while patient is in hospital. If you go to the next slide, you will then see where we speak about our retrospective process. in terms of the retrospective process, it is post-discharge, meaning patient is already home. And what we would then do is that in this instance, you would submit the whole pack through to us. I call it a pack. You would submit your referral letter, your daily progress reports for that period where the patient was admitted. And you would make sure that what is also included, you are telling us the dates of service and the types of sessions that you actually have. Was it a group session? Was it an individual session? Part of the reason we want to know this is because we know, for example, as part of the hospital programs, there are certain group sessions that are supposed to happen. But there's also other group sessions that are happening. And for us to be able to identify if it was a group or individual session, it would really help us. So this information would then be sent through to inquiries@gems.gov.za. And just to mention that there are instances where you do need to motivate for your weekend sessions, as well as a second session in a particular day. So upfront, if you know that this is the case, it is quite important for you to give us that information. What I also want to mention is that this presentation is obviously very generalized, very standard, but it is important for us to actually get all the information in and ensure that we give it to you. So I'll just repeat everything again. The retrospective process would take 10 to 15 days from a turnaround time perspective. That's one. You will submit your email address or your email, to inquiries@gems.gov.za. As part of that email, you will submit your referral letter, your daily progress reports for the period that the patient was in hospital. You must make sure that it includes your dates and the type of session that you actually did for that patient. And upfront, you can let us know if there were any extra sessions, for example, 2 sessions per day. It's important for you to let us know and motivate for it. And any weekend sessions, it's also important for us to know that information. And as I mentioned, this turnaround time would then be 10 to 15 days. While we go to the next slide, it is also quite important for us to acknowledge that I think between the period Jan to March, the turnaround time in our inquiries email address has been longer than that 10 to 15 days. However, the team has assured us that they are currently back within turnaround time, and they are working on it to make sure that we come back within turnaround time, especially if it comes out. But generally, they did confirm with me that they are back within turnaround time. It's also quite important for us to mention that we believe in an escalation process. So as much as I've given you the hospital OTS email address and the GEMS inquiries email address, it's also very important that we mention that if you do want to escalate and you have not received feedback through the normal processes that I've explained, there is an email address that's also written there. It's jamesalliedescalations@medscheme.co.za. This is in instances where you have not received feedback within the initial request. And as part of your escalation, please make sure that you include your query or reference number so that we know what happened to the original request. While we want to solve for your current issue, it is also quite important to note that we want to solve for the actual process itself. And this is why we would actually ask you for this information in order to resolve future problems as well. If you go to the next slide. So we wanted just to take a moment just to go through the challenges that we've actually experienced over the last few months. And part of a lot of providers have actually been complaining that they are submitting information to us. And I think because I'm on this side of the table, I can tell you sometimes it's the quality of information that we get that makes it very difficult for us to make a funding decision. So I thought it may be strange that I'm telling you how a referral is actually supposed to look based on HPCSA guidelines. But what I want to mention is that we are actually having healthcare providers that are writing referral letters on their pads, meaning the healthcare provider. So as an OT, you write a referral to yourself on your healthcare on your pad, and then you get the doctor to sign and stamp. That's obviously something that we would not accept. We do actually have a certain guideline that we actually work according to and we reference. So it is important for you to make sure that it is a valid referral, and it needs to have the practitioner's detail, patient details, the receiving provider's detail, and the reason actually for the referral itself. We actually had a meeting a few weeks ago where our providers mentioned that they're genuinely struggling to get referral letters. So, as we always mention that we do listen in these conversations. So, as a team, we are looking at a process where we can perhaps put together a template. It is something that's still under review, and there is still work that's being done, but it is something that we are working on. I know some hospital groups have created their own template, because I think part of what was being said is there's that fight between the allied health providers and the doctor about, but it's on my stationery, I'm incurring the costs and things like that. And this is what we're actually trying to solve for. I know some hospital groups have created a referral letter at group level or at hospital level where it would be easy for them just to put the patient sticker, the doctor would then sign and stamp, which then makes sense. So we are looking at it. But up until that has been rolled out, it is important for you to realize that we need to stick within a certain a frame or an actual frame. So we use the HPCSA frame, where there is actually a requirement of how a referral needs to look. If you can go to then the next slide for me. We also noted that part of the reason why our cases are not being actioned, or one, we spoke about the letterheads. We also speak about your signatures, your stamps, but also I'll give an example of a DSM form. So the signature on the DSM form does not always match the signature, for example, on the actual referral letter. And these are things now that obviously would make us send it back and question it. But also, I think it's important for us to note that if you submit a progress report or an intervention that you've actually done, but we actually don't have the details, we don't know if this was an individual or group session. We don't know what was actually done. We are actually at a point where some of the progress reports that we're getting are AI generated. We are getting one-liners. We are getting quite little information, if I can call it that way. And it becomes very difficult for us to make a funding decision if you're giving us a one line, but you want us to fund 4 OT sessions for each and every single day. We need a clear understanding as to what is being done for this patient. And if it's retrospective, even better, because you know exactly what you did. So you need to give us those daily updates as to what you have done and what the outcomes were. Part of what we have also noted is in terms of the delays, we spoke already about the group and individual session, because obviously from a benefit perspective, there is also a financial, if you look at the tariffs, it's also important for us to know exactly what you're doing. And also, the last bit, it really speaks about just the process in terms of how you're submitting the information. What we're finding is that, one, not everyone submits to the correct email address. And I understand that at times it's because you're frustrated, you're not getting assistance. But submitting to the correct email address helps us to track long term when we are trying to figure out if this was submitted. If you submit to Itumeleng, and Itumeleng no longer works here, it's going to be very difficult for us to actually pull it long term. And it's important for us to make sure that we are submitting to the correct email and we are submitting the correct information. On our end, we're also committing to ensuring that our turnaround times we are within TAT. We need to ensure that we remain within TAT, and we need to make sure that we don't have any processing delays. The last part is that on page 3 or 4 of your auth letter, that's generally where we would put all the information as to the funding decision that we have made, and it is important for you just to have a look at it. If you can go to the last slide, Dr. Z. Okay. I thought it's important just for me to give you a bit of feedback as to what we are seeing when we process these particular authorizations. So we are seeing multiple patients. So, for example, you will have 10 different types of patients on one email. And obviously, this causes confusion, and we cannot process Itumeleng Majeka's things on Itumeleng Sidibe's things. It's important that providers actually submit the correct information. We already spoke about the incorrect email address and the incorrect routing. We are having things that are submitted to staff's personal emails, and it becomes very difficult for us to track. And then also, the last bit with regards to communication, I do just want to mention that as a team, we have committed to actually working through the process and making sure that it's as simple as possible. And we do engage a few providers so we can just ask them about how they are finding the communication that we are sharing. There is an email that was shared with the actual flow of what to submit, when to submit, and please engage with that communication and submit the necessary information, as it will make your life easier. If you go to the next slide, I think that will be my last one. I'm going to pass back to Dr. Zianda so she can close this off for us.
Okay. Thank you so much, Itu. Just in closing, what we usually get maybe as a question is whether providers should be sharing information with the scheme with regards to the letter of motivation and any required clinical motivation for the patient. And we are governed by the Health Act, the POPI Act, as well as Medical Scheme Regulation and PCSA, in that it is shared confidentiality, similar to how if someone has, I think most of the issues would be about disclosure. So if someone has to disclose their past medical history to the scheme, that is shared confidentiality that they are now sharing with us, and they would share with the provider. So that is covered under there. So the flow is that we would need to have the information so that we can assess according to the scheme rules and funding available for that member's option, and then make the necessary decisions, and then we fund care appropriately. If we do not have the information, we would then don't know how to fund care appropriately in terms of making sure the services are correct. So this is important so that we can contain costs, manage high utilization, as well as making sure the members are protected in that they are getting the services that they need and that are relevant to their clinical condition. And I think just to bring it all to the end, is that for what we've seen in what we've presented now is that the analysis needs us to then have a structured interaction, which is what we have now, so that we can align, as I mentioned earlier on clinical governance, operational issues, and be consistent and make sure that we have shared accountability across the whole service package that we are offering as a scheme and managed care organization administrator, as well as the providers. I will close it over here and hand back to you, Chair. Thank you so much.
Thank you so much, Itumeleng and Dr. Zianda, for that presentation. If we can just please slide the video that we have that we'd like to share with the colleagues, and then I will come back. Thank you.
Welcome to GEMS News, where we bring you important updates and practical information to help you understand and use your medical aid benefits with confidence. In this edition of GEMS News, we reflect on access to healthcare not being a privilege, but a right for all South Africans. We unpack how to access healthcare correctly. We take a closer look at the Tanzanite One option and what it offers. And we explain what you need to know about prescribed minimum benefits. Access to healthcare is not a privilege, it is a right. GEMS exists to ensure that members and their dependents have access to quality healthcare services in a way that is both affordable and sustainable. Let's take a look at the Tanzanite One option. GEMS's most affordable benefit option, designed for public service employees on salary levels 1 to 5. This option provides access to comprehensive in-hospital and out-of-hospital healthcare services through the GEMS Healthcare Network. Members continue to have access to essential healthcare services, including private hospital care when it matters most, particularly for medical emergencies and prescribed minimum benefit. It also includes access to everyday healthcare services such as consultations, chronic condition management, and preventative care when accessed through the correct providers. Prescribed minimum benefits, or PMBs, are a set of conditions that all medical schemes are required to cover. These include serious and life-threatening conditions, as well as medical emergencies such as heart attacks, strokes, severe injuries, and complications from chronic conditions like diabetes, high blood pressure, asthma, and HIV. In an emergency, members should go to the nearest hospital immediately, where they will receive urgent care and stabilization. Understanding how PMBs work and following scheme processes thereafter helps ensure continued access to essential healthcare services. We will explore PMBs in more detail in upcoming episodes. To get the most value from your benefit, it is important to follow scheme processes. This includes using designated service providers within the GEMS Healthcare Network, obtaining pre-authorization where required, and registering chronic conditions for ongoing treatment. Consulting the same family practitioner where possible supports better care coordination and informed treatment decisions. Following these processes helps ensure that your claims are paid correctly and that unnecessary co-payments are avoided. You can learn more about how to use your benefits correctly by visiting gems.gov.za. Members are encouraged to attend GEMS Day events taking place across the country. These engagements promote healthy living, provide access to health and wellness screening services, and offer practical guidance on how to use your benefits effectively. They also create an opportunity for members to engage directly with the scheme and make more informed healthcare decisions. Understanding your benefits is the foundation of making informed healthcare decisions. By using the correct GEMS Healthcare Network providers, following scheme rules, and staying informed, members can maximize their benefits while avoiding unnecessary costs. Look out for G-Health on the GEMS website, where we explore healthcare topics in more detail and support you in making better health decisions. We're here for you whenever you need us. You can contact the GEMS call center on 0800 00 4367 toll free. Visit your nearest walk-in center. Follow us on our social media platforms or access information anytime on gems.gov.za or the GEMS app. GEMS, working towards a healthier you.
Thank you so much for that video. I hope that colleagues, you found the video interesting. What we trying to show you is that we often get asked by providers if we educate our members, on their benefits and just the medical
This
aid.
month's edition of GEMS News, we join the country in celebrating Workers' Day and Nurses' Day.
Apologies for that, colleagues. It would otherwise not have been a webinar if we didn't have not even one technical glitch. Apologies for that. So the video that we've shared with you was prepared for our members. We share it in our social media platforms, just as an additional mode of educating our members over and above the written form education material that we have for them, just to educate them on the benefits. So the presentation that we've just had, colleagues from the managed care organization, I see that we've received quite a lot of questions emanating from that presentation. I'd like to encourage my colleagues from the managed care organization to please attend to as many questions in the Q&A box as possible, colleagues, so that when we get to the Q&A section, we at least have covered most of the questions that are in there. I also have in attendance colleagues from the scheme. If there are questions that are directed at us, can you please also just respond to those, as well as the administrator? Thank you. So we're going to move on to the next item in our agenda, and that will be for claims overview and key insight. It will be presented to us by Ms. Chantel Mbuto. Chantel is currently the head of claims operations in the GEMS Fund Management within Metropolitan Health since 2019. She has over 20 years experience in the public and private healthcare industry, with public and private hospital and medical and administration experience. Her experience in the administration and ops environment involves customer services, provider relations, membership, and customer experience management. Chantal, I'm handing over to you. Please go ahead.
Good afternoon, colleagues. Thank you, Chair. So good afternoon, colleagues. As the Chair has advised, I'll be taking you through a few slides on claims utilization and cost, being cognizant of the time and the fact that we've got much to discuss. This first slide really is an overview of benefit paid to the discipline for occupational therapy. And what we're showing here in the graph to the top left is the total benefit expenditure. We'll be giving you an overview of benefit paid from 2022 to 2025. And this is the full year benefit experience. We can clearly see year on year the increased trend in benefits paid to the discipline. If we look at the 2025 experience,
Chantal, apologies for interjecting. Can you please put the presentation in presentation mode?
Apologies, I thought it was. Just give me a second. Is it in presentation mode now?
Yes, it is. Yes, it is.
Right. Apologies for that. So if we look at the benefit experience in 2025, we paid 334 million to the discipline. And from a year-on-year claims experience, we do note about a 16% increase in benefit paid and about a 22% increase over, from 2025 into 2026. What this does indicate is that there does, tend to be a continuous increase in the discipline spend. And we see this, largely driven by mental health related admissions and rehabilitation services, which we'll share in the upcoming slides. And while the overall benefit has increased substantially between 2023 and 2025, when you see, one of the following slides, you'll note that the 2026 experience suggests, a moderation in growth. If we look at the map to the top right, this is just indicative of the number of visits that we see across the provinces. And you can see Gauteng province, 34% of visits attributed to the province, followed by 14% in KZN and 13% in the Free State province. And those are the top sort of provinces where we see the highest percentage visits. If we look at the graph to the bottom right, this gives an indication of the demographic and utilization profile of our members by male and female. And what we do note that the majority of OT users are adults, generally between the ages of 40 to 70 years of age. In the female population, you can see our female population account for a larger proportion of utilization, peaking at about almost 15%, compared to our male population. We see that in the ages of about 10 to 20, there is a peak there, but really not as significant as a female population. And then the age bands between 50 to 60 years of age. And then just in wrapping up this slide, 62% of benefit paid is for patients in the in-hospital setting, while 65% of visits are also provided in the in-hospital setting. And this does indicate that from a spend perspective, in-hospital costs are, far higher than out of hospital. If we move to the next slide, it is quite a busy slide, so I will try and summarize it. While on the previous slide, we did speak to the overall benefit paid and the increase we see year on year, you can see that it is quite high if we look at the year on year and the 2-year experience, where claims have increased. As much as we see positive, member growth in the GEMS environment, if you compare the benefit expenditure, it is higher than anticipated or expected. What we also do note is that, part of, we explain part of the increase in cost by growth, but it is still substantially above expectation and inflation. And it does indicate an increased demand on utilization, but this is also driven by the increase we're seeing in the mental health conditions. If we look at the number of providers over time, I did note there was a question in the chat about new entrants. What we do monitor is the total number of occupational therapy, I'll say practices, because it's not always clear by the submission of claims whether an individual practice has one or more providers. And I think it also speaks to one of the questions that were put in the chat. Generally, an individual practice number, the expectation is that it is linked to one individual occupational therapist. We do note there are group practices that also exist. If the occupational therapists are operating in a group practice, generally the expectation is that that group practice would be registered with BHF as a group practice. So you are assigned a different discipline type, and then we're able to identify the practice from the group practice from the individual. But this is really just indicating the total number of practices. So it could be individual and group practices that have claimed from GEMS in 2025. You can see it is on an upward trend. with 1,216 practices claiming from GEMS in 2025. And we look at first-time claiming practitioners or practices sitting at 145. We can't categorically say that that is new providers entering the market, but what we can tell is that they've claimed from GEMS for the first time in the respective benefit year. And then from a cost perspective, we do note that 73% of the cost is attributed to the top 10% of practices. And just in wrapping up the slide, what we do see is the average benefit per patient is 4,700, with the average visits per patient at just under 6. So this slide just gives a view of the rejections that we see in the claims data, and this focus is on 2025. And what we do see that most rejected claims relate to benefit rules as well as utilization controls that we have implemented in the claims system. What we see in the rejections data is that 107,000 claim lines have rejected to the value of 32.6 million. This is quite significant. And if you look at the top 5 rejections, they attribute about, from a cost perspective, 76% of the total rejection fees are attributable to the top 5 rejections that we've listed there. So, if we just focus on that, discipline not allowed for this treatment was also a comment I saw in the chat. Generally, providers would, provide a service and submit a claim. If a claim is received and the authorization either has not been approved or the authorization has not been updated, this rejection will apply, because generally the claim will try to match to the hospital authorization, but where the discipline is not part of that approved hospital authorization, there is an expectation that the practitioner needs to request their own authorization. And before the authorization is approved, if the claims are submitted, we tend to see the discipline not allowed for this treatment. It is quite significant if you look at the 2025 experience. However, once the authorizations have been uploaded or updated to include the service dates in question, those claims are subsequently reprocessed for payment. The next one is motivation required. Generally, we do require additional information around utilization. So it may relate to a frequency or quantity limit, or even tariff combinations. We may request additional clinical information for review by the medical advisor. In instances where we see invalid ICD-10 codes on claims, we would reject and request that the correct ICD-10 codes be submitted, and we see that as the fourth top driver of rejections. And then lastly, stale claims, as much as the value is significantly lower than the top 4, but you can see the number of claims is quite high. And there was also a question in the chat that asked which is best for you to submit your claims upfront, although they're going to reject for discipline not allowed. For me, that would be the first prize, because we've at least got a record of the claimant system while you're then following up on the authorization process. And once the authorization is approved, we'll be then able to reverse and reprocess those claims against the approved authorization. So I think just in, summarizing this slide, I think there is opportunity for us to reduce these rejections. We believe that, large proportion of these rejections are preventable. And it also does speak to, us sharing information so that we can also educate providers on what the requirements are from a claims billing rule perspective, but also coding accuracy, I think, is equally as important to ensure that we reduce these rejections. This next slide just speaks to the top ICD-10 code and tariff drivers, giving you a year-on-year comparison. What we do note is that mental health, as I indicated on my opening slide, does appear to be a key driver in terms of ICD-10 codes. We see, F32.2 increased by about 31% year on year. Where in 2025 we paid 155 million, and that is up from 118 million in the prior benefit year. And you can see as we go down the slide, the mental health related ICD-10 codes, either from a depression, bipolar perspective, but we're also seeing it, increases in those ICD-10 codes relating to alcohol and substance abuse. And that is also what is coming through in the data, not only for prior benefit years, but also into 2026. If we look at the top key tariff drivers, we do note that there is some significant tariff growth in some of the tariffs. I won't go through each of them, but I think perhaps just to highlight the 66315, we can see there that tariff has increased significantly by 54% year on year, having paid over almost 41 million when we paid just over 26 million in the prior benefit year. So, and as you go down, you can also see the 66410, which is up as well by 54%. Sorry, not 54%. It is up by 49%. And then the 66313, which we're also seeing some significant increases in claims cost and utilization, that is up by 42%. So I think just before moving to the next slide, it is important, I think, to note that what we are seeing is longer therapy sessions and rehabilitation services that are driving costs from a tariff code perspective. And as part of our ongoing analysis and engagement, we do review appropriateness and the outcomes associated with the increased utilization that we see in the claims data. The next few slides are very similar to what I've shared, so I won't go into too much detail. This is just giving you a year-to-date view, so comparing prior benefit years, but bringing in the January to April experience. And as I indicated on the opening slide, that as much as we've seen year-on-year increases in spend from an OT perspective, looking at the January to April 2026 experience, we are tracking below the 2025 experience. I think important to note that with the operational process changes, we do still expect to see significant value of claims being reprocessed once the authorizations have been approved and updated, so that 113 million, where we note a decrease of about 7% year on year, is subject to change. If we look at the map, it's really very similar to what we presented on the prior slides, as well as from a benefit percentage during an in-hospital admission. It does remain fairly, aligned to what we see in the year-on-year experience. This next slide, I'm not going to go into much detail, but just to indicate into 2026, we are still seeing first-time claiming providers in the claims data. And as much as, we do note the positive member growth, the increase or decrease we're noting in the benefit expenditure, as I indicated, is subject to change. And later in the year, we'll have a fairer picture of what the actual cost is once the authorizations have been updated and the claims are subsequently processed. The cost per patient, however, has increased by 3.9% year on year, and by 10.3% over a 2-year period. And the total number of claiming providers, as I indicated, is also reflected there. If we move to the next slide, similar picture that you would have seen as the 2025 experience. It really is not very different, except maybe we see one or two other rejections coming into the fore. Utilization limit exceeded, motivation required. Also, tariff item payable once every 3 months. So that is also coming there. We do note that there has been approval or adjustments to some of the billing rules from an OT perspective that was communicated in the last month or two, where we have actually adjusted and opened up utilization on some of the OT tariff codes. If we move to the next slide, it is a fairly similar picture to the one presented on the top ICD-10 codes and tariff code drivers. But what we do see in the 2026 experience is that certain ICD-10 codes, we are noting some significant increases. As I indicated, mental health ICD-10 codes on the rise. We're seeing acute stress reaction coming into the top 10 by quite significant value at 2.5 million compared to the 1.1 million in the prior benefit year. And then also the alcohol or substance abuse also increasing quite significantly there. And the F13.2, if you look at that, was almost, not even reflected. We didn't even reach payment of 100,000 in 2025, and now we've paid benefit to the value of over 1.3 million. So we are seeing this increased trend into mental health in the OT space, and it is, a significant driver of costs. If you look at the tariffs view in 2026, as I indicated, we've note a reduction in the overall spend by 6.9%, and you can see which of the tariffs we are seeing a reduction in the overall costs year on year. But as indicated, we're still expecting significant volume of claims to be processed once authorizations have been updated. The next few slides speak to fraud, waste, abuse, and error. Error is a new element that has been introduced into the fraud, waste, and abuse space. We have been asked just to share with the colleagues a few slides on the trends that have been identified. And here, really, one of the trends that have been identified is trends of abuse commonly seen during admissions for PMB conditions. There's significant expenditure risk that has been identified through utilization reviews. We've got a claims risk team which will review, claims patterns, but also compare against peers that are treating patients in the in-hospital setting for similar or same type of diagnosis. The focus really is on excessive billing. We do note duplicate services and poor documentation, where practices are requested to provide additional information. It is not always clear as to the treatment that was provided. Another trend that we asked to share is that there is, and we'll see into the next few slides where it actually goes into one or two examples where OT providers are claiming up to 4 hours of sessions per day per member, therapy either as group or individual sessions, evaluation and consulting, where multiple OT practices are also billing on 1 day. Clinical notes really not reflecting the sessions that are claimed for, and inadequate documentation to support combination of codes billed, especially interviewing and evaluation codes. And I know, in discussion with some practitioners, they do feel that they don't want to share clinical notes as it is confidential information, but as part of the audit process, there may be a request for clinical notes to be shared. billing of more than one group session without documentation of what each session entailed. Examples that were cited here is billing of 305 and 308. Misalignment between the duration recorded on the notes versus, compared to the actual codes that have been billed. Template billing, this really is where sessions are billed without consideration for clinical feasibility, and you tend to see the same codes billed, on each claim for each patient. In this scenario, there was daily billing of 401 on severely ill ICU patients where the condition remained unchanged. And then lastly, lack of coordination of therapy provided between multiple practitioners and disciplines consulting a patient on the same day. In the mental health space, we do see patients being consulted by, multiple providers, social workers, psychologists, registered counselors, etc., with multiple sessions being done across the various disciplines. So this first example is an experience of a single day where almost 8 hours of services were billed for a single member. It is 2 group OT sessions with 1 individual OT session plus therapy, by the psychiatrist, psychologist, physiotherapist, dietitian, and social worker. As seen here, you can see that the member was admitted for a mental health condition, so severe depressive episode, and was seen by the psychiatrist, by the OT, for group as well as individual sessions, seen by the psychologist, again, seen by a physiotherapist for neck pain, dietitian as well. So this is just some of the experience that we see in the claims data when we do this analysis, and it is quite concerning from a cost perspective. And you see this over multiple days, sometimes throughout the patient's stay in the in-hospital setting. This is but another example of 2 hours of group OT sessions and 2 individual hours of therapy delivered by 3 different practitioners. And you can see it's OT number 1 cited there. Then they were seen by a psychologist all on the same day. Then OT number 2 and OT number 3. So these are individual or unique practice numbers that are being billed against the admission for this particular patient on one day. Okay, I'm almost wrapping up. So this is really just a case study that we were also requested to share, where as part of the claims that are received, there is a profile review that is conducted or that was conducted due to a preliminary review that indicated there could be potential overbilling, and the investigation did identify irregular billing practices, which had to result in recovery action being taken. What we do see is that there was irregular billing of tariff code 66431 and 66211. There were time-based concerns that were raised, and numerous member disputes were also cited. Practice locations were not verifiable by site visits, and there was engagement, with the provider to understand the billing behavior, and the provider had advised that no consent forms were kept, proving services were rendered, no notes of the time spent attributed to the member disputes, and there was downgrade of tariffs that was agreed by the provider. And there were remedial measures that were applied, where the report recommended category 2, we've included there just the definitions of, what category 2 means. I'm not going to go into the detail, but I think just important to note that the outcome of this investigation resulted in a recovery to the value of 314,000 from the particular provider. So I think, we just really wanted to share with the colleagues what we are seeing from a claims cost and utilization perspective in the claims data. And as part of our ongoing, efforts to manage, claims cost and utilization, we continue to monitor the expenditure across all disciplines, and not only for occupational therapists, and where we do note significant increases in costs from time to time, it does warrant, investigation into certain providers. And I think just to note, mental health is of a particular focus because we do see these significant increases in spend. I think I thank you for the time, Chair, and I'm happy to pause here.
Thank you, Chantal. Thank you very much for that presentation. Colleagues, apologies, I realize that we've gone over our time that we had planned for the session, but I do hope that you found the presentation from our administrator valuable. We're going to go straight, colleagues, to the Q&A section in the interest of time. So I see that we've received quite a lot of questions already in the Q&A. Thank you so much for that engagement. I think my colleagues have answered about 72 questions that were sent, and we still have some questions that are open. We appreciate the engagement, colleagues. This is the reason why we're here. We came to you so that we can support you in terms of your operational challenges. We just want to highlight to you that our processes are in no way intended to antagonize or frustrate you, which is the reason why we come to you to explain our processes and hear from you in terms of your challenges and support you so that you don't sit frustrated with our processes when that is definitely not our intention. So with that said, the plan for the questions that we've received, whichever questions we are unable to cover during the session, we will compile, in actual fact, even the ones that we did cover during the session, we'll compile a Q&A document that we will share with all the attendees of the session, so that it will probably be in a more collated, summarized manner so that you can see the type of questions that we received and we can provide you with answers. Some of the questions that we received would actually be better approached that way instead of trying to answer them during the session, so we can give you detailed feedback to all of your questions. So please do not worry about that. We'll ensure that you have that information. Then in terms of the recording of this session, we'll also record, we're recording the session. We will post the recording in our provider portal as well as the provider app. So colleagues, if we are not registered in those platforms, I'd really like to encourage you to please register so that you can have access to the recording. There's a media section in both the portal and the app where you can click. You can actually even view previous sessions that we've had, especially our summits that we've had, if you're interested in viewing those recordings. So I'm going to prioritize hands in terms of taking questions in the interest of time. So colleagues, if you have any questions, I'm going to now encourage you to please raise your hand so that we can take your questions. Then in between, if I'm not getting a lot of hands, then we'll go through the questions that were sent in the Q&A box. To be efficient, I'd really like to encourage my colleagues from the managed care organization and administrator, as well as scheme colleagues, to please raise their hands as quickly as possible after I take the question to provide answers so that we can be efficient with time. So I am going to then proceed, colleagues, and take hands. So if you have questions, please go ahead. I have a hand from Michelle Patricio. Michelle, if you can please unmute and then proceed with your question.
Hi, can you hear me?
Yes, we can hear you.
Thanks. I would just like clarity on this daily progress report that we have to do. First of all, we weren't told about this change that was made. Randomly, when we were querying why claims weren't made or why claims weren't paid 2 or 3 weeks ago, we were then told that now we have to supply these daily progress reports. So I don't know when this rule changed and why it wasn't communicated to us, but it's made it very difficult now to retrospectively go back to all our patients over the last few months on claims that haven't been paid to now go and do all of this admin for all the patients. So I just wanted to ask that if rules like this do change, if appropriate communication can just be given to the companies, because we are sitting and wasting time emailing, calling, and chasing on claims, and then randomly just get told, oh no, this is a new rule that's just come up. And then we submit a progress report, one person accepts it, then I submit the same kind of progress report for another patient. Then that person comes back and says, no, you have to add this and this information, but another person approved it, and now this other person has a problem with it and says I must give other information. So I'm just finding that it's not consistent. And even when I do eventually get hold of someone, often when we call, they say, no, they can't answer. There's high call volumes. They'll call us back later. And then they don't even call us back later. But when we eventually do get hold of someone, we say, okay, what must be in the progress reports, because people are telling us different things. And then the people who are processing our claims say they don't even know what's supposed to be in the progress reports. They were just told this recently and they don't have a clear idea of it either. So it's made this whole process really difficult. And now even getting our claims paid, everybody's coming with different things, and I'm having to submit multiple reports with different information for different people because they're not having a clear understanding of what is needed.
Thank you, Michelle. Thank you very much for that question. I can see a lot of hands clapping. I'm assuming that colleagues are sharing your sentiments and also asking for the similar, or are rather experiencing similar challenges and needing responses. So Itumeleng, please respond to the colleagues.
Thanks, Sandy. Hope you can hear me. Sorry, I was just writing as we go along. So in terms of the communication, maybe let's start there. So communication was sent on individual cases between July and I want to almost say August, or maybe even October. So if you look at page 3 or 4 of the auth letter, that's where we would have said going forward, you would be required to submit 1, 2, 3. Further to that, communication was also sent in December to the actual allied health providers, and also more recently there was a flyer that was communicated. So in saying this, I'm not saying that our communication was effective and clear. I think as we are going along on this journey, we are noting that we need to write our communication in a simpler way. As you mentioned, if our staff perhaps aren't even understanding, we do need to do better and train better. So, Michelle, I think your name was. So firstly, I want to apologize for the service. We definitely have committed as a team to communicate our changes before we actually go live, because we perhaps have taken it for granted that providers do read our auth letters, for example. So as part of our plan for this year is you will see with the different things that are going out, we will be actually communicating upfront. So in order for us to change or try to make it different, that's why we are having these sessions, we're having the webinars, we are actually engaging the providers to try teach and simplify the messaging, because I think it's important for us to simplify that. Then lastly, in terms of the different answers, I think I've been getting this quite a lot from different providers, and I almost want to say there is no one size fits all. And I want to perhaps add to a statement I made earlier. I said we need daily updates, right? So it does not mean every single day you need to update us. You can do a consolidated view retrospectively on a daily basis. I think what we are trying to understand is what you have done for that particular patient. And I think that's why it can't be a one size fits all, because there's no two patients that are the same from a clinical perspective. And that's why we want to understand. Perhaps we shouldn't even call it a progress report, because that's the language we use with hospitals. Maybe we need to start calling it an intervention report or something. We actually just want to know what you have done with the patient, because I think that's the part that's very important for us. And I know the frustration with some of the providers I've spoken to is, you approved it for this patient, but not for that patient. Why is that? It could be that perhaps the number of days were different. It could be that the clinical information should be different, but it looks very similar. As I mentioned earlier, there are certain providers that give us, for example, AI generated or like a copy and paste of another patient. And that's why the team is so, from a clinical perspective, they want to understand what is it that you're doing for that particular patient. But also, maybe just to mention, we're also looking at our internal processes from end to end. So the feedback that we're getting in the chat and in the Q&A, we are definitely taking it back. And if some of the examples can be shared with us, please do that, because we want to learn from this experience. We don't want to just come and talk. We want to learn from this experience. We're going to take it back, and we're definitely going to do better. Thanks, Sandy.
Thank you, Itumeleng, for that response. I'd like to give my senior manager, Ramuela, a chance to also come in here before I take more hands. Ramuela.
Yeah, no, thanks, Zandi, and thanks, colleagues. I just wanted to add from a positive side of things that one of the learnings that we have made in our environment is that whenever we do any change, we need to first give all our healthcare practitioners sufficient time before we go and implement. And that sufficient time also involves engaging some of the key stakeholders like OTASA as an example, or any other formation to take them through what we are thinking and what we are planning to do. And we do get valuable insights to help us to correct some of the things that we wanted to implement. Now, the challenge that often arises is now when it comes to individual practices, contact details that we have on our systems, be it emails or even cell numbers where we may need to send an SMS. Some of the contact details that we have on record are not up to date. I mean, even this webinar, this evening as we are having it, we do get a report in terms of the distribution of
I lost Ramuel. I'm not sure if it's just my network
Yes.
issue. Can someone confirm?
Yes, I've lost him too. His video is
Okay.
frozen.
Thank you, Dr. Zianda. Ramuel, if you can hear me, we lost you there. I'll allow you a chance to come back later. But in the interest of time, I'm going to take more hands. Colleagues, we are working with limited time now, so I'm just going to ask you that when you ask your questions, if possible, please try and keep it brief. I know that in the last questions, Itumeleng responded to quite a few other questions that were raised in the Q&A box just around the feasibility of sending daily updates, and colleagues sharing that they prefer to rather send the updates retrospectively. So I'm hoping that majority of those questions that are in the box were also covered. With that said, I'm going to take the next hand. I have Harriet Likalaga. If you can just please unmute and go ahead, Harriet.
Hi, am I muted?
We can hear you. You can proceed.
Hear me?
Yeah.
Okay. Question is a follow-up on Michelle's question. Sorry. with regards to the whole process, well, I did get a communication in the beginning of the year, which I missed last year, with regards to sending a progress report. So my question is, in terms of the prospective authorization, so OTs are not always the first online to request that. So we always get a referral. Say maybe the patient will be in hospital for about maybe 10 days or 20 days, and then we get a referral. Then the way I understand the process is I'll get a referral letter from a referring specialist, and then I'll maybe provide a service for the day or two, and then submit the two. But what happens afterwards? While I'm waiting for the 10 to 15 turnaround time, do I see the patient or do I not see the patient? If I continue to see the patient and it comes back as rejected, then what happens? So now that is one of the frustrations. And then the other thing is, we thought in my practice is that um, maybe we might as well just wait until the end. But that is even more non-profitable because we will see a patient for 10 sessions or 15 sessions and then write everything that we did. And then turns out, okay, like from the clinical reasoning, we don't know why you are seeing a patient with renal failure or something like that. So, which is something that I think more we need to get more people from GEMS to understand what OTs do. So hand therapy can be broad. I don't want to elaborate on this, but you can get a patient with renal failure that needs hand therapy, like maybe a fistula is blocked and then it causes a radial nerve and so on and so. And then on the other thing, quickly, if we have to motivate in terms of the treatment plan, how many sessions? How do we decide on how many sessions for an inpatient? Because this patient is in hospital. So it's just totally confusing because we see the patient for 2 sessions and then it says 1 days or two. I don't know why it says 1 days. And then we wait forever to get a feedback when we do, and it's like insufficient information. And then you do submit that information, and then they say you must tell us how many treatment sessions you need. How do you decide on that? The patient is in an in-hospital. In outpatients, of course, outpatients we can make a plan and say, okay, we're going to see the patient for 5, 10 sessions. But inpatients, the patient is there. You see PRN. So you might end up seeing the patient from December to March, but you see as required. So now I don't want to ask many questions. I do have a lot of questions, but let me give other people a chance. Thank you.
Thank you, Harriet, for the question, and I'm sure that the MCO colleagues did hear the questions clearly. I'd like to just take one more hand before I hand over to my colleagues to respond. Teresa, I'll take your hand next. If you can just please proceed. Please unmute and go ahead.
Hi, can you hear me?
Yes, you are audible.
Hi. Okay, sorry, it's Sylvia speaking. I work for Teresa Swart, occupational therapist. Okay, these are just sorry. I just want to quickly just try and see where my question was. I took a photo of it. What I want to know is how do I get a tariff code for a nappy code? I've got a nappy code, 2 of them, and I was told by the company that gave me the nappy code to speak to the medical aid. In this case, it's GEMS. I phoned on Friday, I phoned again today, and the consultants can't assist me. I phoned the company that gave me the nappy code, and they said I must contact SAMA, South African Medical Association, which I also think is a bit weird because they want you to be a member, so they want payment before they give you an answer, to give me a tariff code for a nappy code. So I just want to know if I can be assisted on that.
Noted, Sylvia. Colleagues, I'd like to then go back to the first question that we received from Harriet. Itumeleng and Dr. Zianda, can we please have a response? The question was around the prospective auth process. What happens after the first 2 sessions have been authorized? In terms of continuing treatment, Harriet did provide a lot of context to her question. Can I just please have a responder?
Thanks,
Dr.
Sandy.
Zianda, thank you.
Sorry. Do you mind if I reply to the second one while it's still top of mind?
You can go ahead, Ida.
All right. So the nappy code for the toilet seat. So James has an appliance list on the actual website. It's the medical device list or appliance list. Have a look if it is part of that list, and it would also tell you how much we're actually willing to pay up to. It is like your nappy list. So I think for any appliances, it would be best to consult that particular list, and you should be able to get that information. And then just to go to Harriet's questions or requests. So I want to almost say there are pros and cons to the prospective process as well as the retrospective process. And part of the reason we cannot dictate which process you use, it is dependent on your practice and how you run your practice. So if I'm speaking about the prospective process, and you submit, because patient is still in hospital, you submit, there are practices that submit weekly updates to us, right? So every week, let's say patient is in hospital for 20 days, they will say for the 20 days, I'm going to rather split it every 5 days. So therefore it becomes more admin intensive. But that way they know that they are getting their authorizations timeously because they are now using the hospital auth's email address. Also, you can submit a treatment plan, but generally with a treatment plan, the team is going to be approving a few sessions. Then they would actually need more information as to what you have done from an intensive process. And then the retrospective process, you do get an approval for all your sessions in one go, or a funding decision of all your sessions in one go. However, the negative part of that would be if, for example, we are saying something, for example, from a clinical perspective, we are not funding. It does not make sense financially for you as a business, and that's why it's a bit tricky. But the one thing that recently I had a meeting with one of our other providers, and as a provider, you are very knowledgeable in your craft, right? You know exactly why that patient needed, for example, hand therapy. You know exactly why a patient would need hand therapy, but they're there for dialysis, etc. On our part, we would not know what you know and what you see in the hospital. And that's why it's important for you to take us along on that journey, right? So in an instance where we are saying something is not clinically justified, one, you have the right to appeal our decision, right? So you will appeal our decision and say, clinically, this is a motivation as to why this patient needed to actually continue with treatment, right? And then we will submit that to our medical advisors, who will then review the decision and give us a different decision. What we don't want to do is frustrate you as providers and say, the first decision you get is it. No, share the clinical information with us, because remember, we make a decision based on the information that we have. And I think sometimes the assumption is that the hospital has given us information, or the treating doctor has given us information. The amount of information we get as a funder is very limited. Even the hospital at times do not give us the full picture. And that is why it's so important for you as an allied health provider or as a practitioner or as a clinician to take us along on the journey, make us understand and make us be comfortable to make that funding decision. You are there to make the clinical decisions. We are there to make the funding decision. So we are not questioning you from a clinical perspective. All we are saying is for us to be able to approve, we need certain information. And a lot of the time, we are not getting that information. And that's why it's so important for you to actually give us that info. And in an instance where you really feel, I think you're not the first person to speak about hand therapy. I saw in the chat there were a few people that spoke about hand therapy. We are open to feel free to share like journals with us if you feel like this is information. We do engage with OTASA on a regular, and these are some of the conversations we have where they feel like their profession is misunderstood. They do educate us. So you can come either via them if you belong to them. Otherwise, share that information with us. We'll send it to a health policy unit and they will definitely look at it and see if it's a funding policy that they can look at. I think those were the two items. Sorry. Thanks, Sandy.
Thanks, Itumeleng. I see I do still have some hands. Colleagues, I'm looking at the time. It's 10 to 6. We initially scheduled this meeting until 6 o'clock, but we did run over with our presentations. So I'd just like to request, please, if possible, that we just ask for an additional 10 to 15 minutes max, maybe 10 minutes for the questions and 5 minutes to wrap up. We will just see how we do with the questions, but I'm committing to ensuring that we are done by 6:15. So I'm seeing some thumbs up, and I appreciate that, colleagues. We really do value your time. We know that your time is money, which is why we try to schedule this meeting for the afternoon from 4 to allow you to at least have a working day. So we truly appreciate you being here. So I'm going to continue taking questions. Like I said, I'm still prioritizing hands. I have Humeria Khan. If you can just unmute and ask your question.
Hi, thank you so much for this platform. I think we as OTs really appreciate this to be heard. So thank you so much. My question today is also mentioned in the Q&A regarding PMB reviews. So I've had an experience where I had a member that was seen as an inpatient with a neurological condition. The claim was accepted for payment, but the benefits were exhausted. Now, I don't know where to. I've escalated this with hospital auths. I've submitted the motivation, etc., the referral letter. I've gotten the authorization number, but I faced a difficulty where the PMB in hospital department has told me that they do not do PMB reviews for allied health practitioners, and client services manages this. However, client services have advised that it is the PMB in hospital department or channel that we should be communicating with. This has led to me having to escalate this multiple times with client services, team leaders, etc., but still have not gotten any response on who to direct this to in a case where it is a PMB condition. It's a PMB auth. The hospital auth is being flagged as PMB, but the claim has been approved but not paid because benefits are already exhausted. Thank you so much.
Thank you. Thank you for that question, Humeria. Itumeleng, we are back to you. And I see Chantal also come on. So colleagues, please, I'm going to start with you, Itumeleng. If you can please respond and hand over to Chantal.
Thanks. So please share those examples. So firstly, because I would really just like to understand what's happening there, but my understanding is you would submit 2 inquiries at GEMS, but in the subject line you would say PMB review, and it goes through to our PMB team that would actually then make a funding decision and do like what we call a flag on our side, and then it would go back to the administrator for reprocessing. So the process via email would be to go to inquiries at GEMS, but in the subject line you would then put PMB review, and they should be able to make that funding decision. But also I would just like to ask you to share, because our PMB call center should be able to assist. So if you share those examples with me, so we can start looking at those for training purposes, please. Thanks.
Thanks, Itumeleng. Chantal, would you still like to come in here?
Thanks, Chair. So we will look at those examples together with Itumeleng from an auth to a claim perspective and see how we can assist. Thank you.
Thank you. So colleagues, in terms of examples that are being requested, we have an interim channel that will open up to the attendees of this meeting. I've just requested my colleague to type the email addresses in the chat box for all of you. So it will use two email addresses. One will be mcopr queries at medscheme.co.za. Please don't worry about that. We'll put in the chat. And we just ask that you copy the summit's email address, which is summits@gems.gov.za. We will open this channel up to you until end of this week, until Friday, so that you can escalate your examples that we've requested or any additional example to substantiate your questions that you post in the chat box, so we can try and assist you with your outstanding queries. Outside of Friday, colleagues, from Saturday, we will not attend queries sent through these channels. You have to use the escalation channel that was shared earlier on in the presentations. Speaking of presentations, we'll also share a copy of those with you. And as I said, the recordings will be posted in our portal as well as our app. So I'll move on then, colleagues. Please do share those examples as requested by the respondents to your earlier question regarding PMB. Jennifer, I have your hand next. If you can please go ahead. You can unmute Jennifer and speak. I'm not getting a response from Jennifer, colleagues. I'm going to move to Lebogang. Lebogang, please go ahead.
Thank you so much. Thank you so much, colleagues. I think my question is also just with the few questions I've seen, but my question is more related to the OT billing in a psych inpatient facility. So I think James, you guys have been questioning the OT 3-hour or the 4-hour billings from an OT perspective. So I think so far I would like to understand your context or your thinking about what OTs does in a psych facility. And then also my other question is just, for example, the example that you made about you get in a psych facility, you have OT billing, you have OT groups billing, you have psychology, social work billing. I think my other thing is just also that we don't do the same job. So also, what is your context or your understanding behind the treatment that is basically done in a 21-day inpatient psych facility? Thank you.
Thank you, Lebogang, for that question. I saw it a lot as well in the Q&A box. So I would like to maybe go back to Jennifer to try and see if so Jennifer, you've lowered your hand. I assume that you don't have a question for us anymore. Colleagues, is there anyone who'd like to speak to the question that Lebogang has asked? I initially thought when I saw it in the box, it's one of the questions I thought might be easier to respond to in writing as well, but I'd like to allow you colleagues to respond. Ramuelo, you can go ahead.
Yeah, thanks, Chair. So, colleagues, the scheme is looking into the in-hospital mental health related work that is being done by various disciplines, from psychiatrists, social work, OTs, and all the other disciplines that are involved. So there is a task team that has been formed from an academic institution, So I think what we'll be doing with that task team is to look into all these issues that you have been raising. Remember, as much as we are also clinical, we are not in private practice, we are not in practice ourselves, but we rely on some of those insights from yourselves. So on that one, there will be a position statement that will come from that task team that has been put in place. So they are currently busy with the work, and of course, we will also be including the occupational therapist into that session to assist with inputs to guide the scheme on what the discipline is all about. We are looking into the scope of practice. We are looking into some of the clinical protocols and guidelines. We are looking into the coding structure and the billing guidelines that were mentioned earlier on. We are looking into some of the challenges around the fraud, waste, and abuse that we are seeing. We may think it is fraud or waste or abuse, but things may not necessarily be the case. So that collaboration is very, very important for the scheme. So it's one of the things that we have been tasked with ensuring that we involve everyone, and we all sit on the table, we all discuss the issues, and then we all agree. So be rest assured, the scheme is looking into this matter, and then the responsible or respective body that represents occupational therapists will also be drawn into that discussion. So we will keep you posted, but for this NHM's member and how we can work together to resolve. We are literally here to help. We are here to hear you and to assist where we need to do so. It is in the best interest of the scheme. It is in the best interest of GEMS members, and it is also in the best interest of yourselves as our valued stakeholders. Thank you. Over to you, Zandi.
Thank you, thank you, Ramuelo. Thank you very much for that response. I'm seeing a lot of hands being clapped by colleagues. I think they appreciate the response. So colleagues, I am not seeing any more hands in terms of questions. I would like to just give you an opportunity if you want to speak to a question that you posted in the Q&A that we have maybe not attended to yet. I see you've answered 116 questions already. But I think in the interest of time, colleagues, I'm not going to try and go through the questions because some of them are similar. And I would assume that my colleagues fielding the questions have probably left questions that will be better responded to in writing. So I'm not going to try and go through them. But if you posted a question in the Q&A and it hasn't been attended to, I just want to give you a chance, colleagues, to please raise your hand. You can literally read your own question in the Q&A or tell me your name and I'll read it for you. I don't want to miss an opportunity to give you a chance to raise your concern. Ninette, thank you so much for your hand. You can proceed. You can just unmute and speak. Ninette, I see you unmuted, but I'm not hearing you. Can anyone hear Ninette, colleagues?
Hello.
Yes, we can
Hi,
hear
can
you.
you hear me now?
Yes, we can hear you. Yes, we can hear you now. Please go ahead.
I just wanted to find out, is there a limit on the use of the code 6620201 if we use it with 66311 or 66315? Because we've had we normally bill with code 66201, and it normally gets paid, and then all of a sudden we get a rejection, utilization limit exceeded, motivation required. This is, and then the next 10 invoices get paid, no problem, for the same client, and then all of a sudden it gets rejected again. Is there a limit on the use of code 66201?
You can go ahead, Chantal.
Thank you, Zandile. So yes, there is a limit, and there is a communication that was recently shared. Perhaps we need to just find out if we can share it more broadly with the stakeholders. But the
Okay.
communication was shared with OTASA. So 66201. We have increased the frequency limit. So in my presentation, I did indicate that there were some changes to the billing rules. So we have increased the frequency limit on the tariff code, and it may be claimed 3 times in a 7-day period, and it is applicable across both in and out of hospital. However, there are billing rules that are applicable where 201 is billed with 203. And in the instances where it is clinically appropriate, then the option of submitting a letter of motivation or additional clinical information is requested for review.
Okay.
Thank you.
All right. Thank you so much.
Okay. Thank you for that question, Ninette, and thank you for the response, Chantal. I see that I have one additional hand. So Ninette, it sounded like you had a follow-up. If there is a follow-up, you can ask. Otherwise, I'm going to move on to Elaine. Are you comfortable with the response? Ninette, I'm giving you a chance to confirm if you are comfortable with the response. Okay, I'm seeing a thumbs up.
I'm fine, thank you.
Okay, all right, no, thank you. Elaine, please ask your question. You can just unmute and ask. Elaine? I'm not hearing you yet. I'm not sure if it's my network now, but I can see that you are unmuted. Colleagues, can anyone hear Elaine?
No.
No, Chair.
Okay, I'm moving on to Michelle. I think it's late in the afternoon now, so technology is not coming to the party. Michelle Patricio, please unmute and ask your question.
Yes, can you hear me?
Who's speaking? Is it Michelle?
Yes, can you hear me?
Yes, I can hear you.
I just wanted to ask with the daily progress reports, if we are seeing, for example, patients in ICU where they are not progressing daily because obviously of the severity of their injury, and our treatment doesn't change daily as well, what do we do then for those progress reports? Because on a day to day, there's no change. It might be a few days or a week or two before they have any change. So what do we do then when we are requested daily progress reports for those patients, and then it's a while before we get any change, but they do still require that daily input for therapy?
Thank you for that question. Itumeleng, you can please proceed.
Thanks, Zandi. So, Michelle, in that instance, that's the information you actually need to give us. That patient is currently in ICU. There is no progress from a clinical perspective. However, these are the interventions that you are doing on a daily basis. We need to understand your interventions, and it's really up to you to actually share what you are currently doing with the patient. If there is no movement or progression from a patient perspective, that's fine, but just make us understand from a clinical picture perspective so we are able to make that funding decision.
Yeah, I have been writing that in the emails and I just keep getting the same response back. So I think maybe that's something then also to just go over with your teams, is that in certain cases there's not going to be daily changes and daily progress, because when I do say that and I show here over a 2-week period or over a month period, they've had this progress, but they haven't had it over a day. They still wanting me to give detail on what I've done per day and what the progress has been per day. So there's a bit of a disconnect there on on what we're saying and what they're understanding. And it's just requiring that back and forth, multiple emails, and, just delaying the whole process of claims and payments.
Thank you for those comments, Michelle. Itumeleng, I'm sure you took note of them. Michelle, if you'd like us to look into specific cases, please utilize the email addresses that we've shared in the chat. As mentioned, colleagues, we've opened up those escalation channels to you until close of business on Friday. So if you'd like to share any examples or support any of your questions that you've shared with us, please email them. We've posted the email address. It's mcoprsqueries@metskim, as well as please make sure that you copy summits@gems.gov.za. Time is no longer on my side, colleagues. I did commit to us wrapping up at exactly 10 past so that we can have some closing remarks. Elaine, I know you got cut off earlier on. If there is any way at all that you could please ask your question in a bullet points form within seconds for me, please, Elaine.
Hi,
Lolita,
can you?
sorry, Elaine, I can hear you, but Lolita, I'm sorry, I'm not going to be able to take your hand. My last hand is going to be Elaine. Very briefly, please, Elaine.
Hi, I just want to make sure you can hear me.
We can hear you.
Wonderful. I just want to know, I've spoken to my colleagues, physiotherapy, dietitian, those people, and they don't seem to have the same challenges of the referrals that the occupational therapist has. So we are required to have the referral on a doctor's letterhead with the signature. And I do, to a certain extent, understand it, but I don't understand that it's not being applied to other professions. So if a doctor make a referral to a radiography, they write on their pages, and that's fine. But with our things that are being much more strict and much more difficult, it's time consuming for us. It's frustrating for the doctors because they feel like they have already written a referral. They are a specialist that is trained and has learned many years to be able to refer to a speciality like occupational therapy, and then our referrals get denied. And then we have to go back to the doctor and say, listen, your referral was not significant and not good enough. We need additional documentation on your letterhead because the referral that you have written out. Do you know how frustrated the doctors are? And then above all that, the patients get also very frustrated because their claims get denied because the referral is not good enough. So I just want to know, I know you guys are working on templates, but this is not working. It's also not fair to our profession that we have to work so hard just to get a referral that is good enough for you guys. So I just want to know, is there any way that you guys can work on that, or just maybe, I don't know, review it in your management system? Because we also want to provide good care for our patients, and obviously we can't do that if the referral, the first base of the first step of the referral is problematic. So please, can you guys assist me with something that can work better in the longer run?
Thank you very much, Elaine, for your question. It seems that somehow technology made sure that we leave you for last, because I'm seeing a lot of hands and a lot of hearts. Your colleagues are supporting your request. Dr. Zianda, I'm not going to ask you to respond, please. I'm right for Ramuelo to wrap up for us. I think the question, or rather the request that was put through by our colleague Elaine, he can be able to also factor it into his wrap up closing remarks. So thank you so much, Elaine, for your comments. They are recorded, they are noted. But in the interest of time, colleagues, and they will be attended to, we do assure you that. In the interest of time, I'd really like to start wrapping up the engagement. Thank you very much for your time. We have lighted a QR code for feedback survey. I'd just like, before I hand over to Ramuelo to give us closing remarks, to please encourage you to scan the QR code and please give us feedback pertaining to the session. There are some open-ended questions that we asked, especially around what do you think we can improve around just the webinar and in general, please feel free to share that feedback with us. But also we have given you those email addresses to speak to us. So Ramuelo, he's also affectionately known as Billy. I think it's the end of the session now. Billy, we can give them your other affectionate name. The colleagues know you now. If you can just please come through and give us some closing remarks. Thank you.
Thank you, Zandi, and thanks, colleagues. I think from us, the scheme, this is a great moment to have such an event with occupational therapists. And to answer maybe the last speaker, Elaine, the reason why we're having this webinar, it's not necessarily only with OTs. We have physiotherapists, we have social workers, we're still going to have even dietitians, biokineticists. So the problems that you are experiencing are not only limited to OTs, they are also being, we also mutually having similar challenges. So we felt it would be prudent to split the disciplines so that we can give each discipline its focus, attention. So the others are still going to follow. I think we have got another one on the 10th. I think with the physiotherapists and then social workers will follow later, and other professional bodies within the auxiliary and allied spaces. But as indicated in our opening remarks, we don't hide behind documents, we don't hide behind call centers. You've seen some of the colleagues who are directly involved from an operational processes that are in place from Metropolitan Health and MESKIM. And main objective of today is to hear you, is to listen to some of the concerns that you have. And it is through this engagement that we gather some information that will help us also to correct ourselves, because we need to be corrected. And without you doing that service to correct us, your services will also not get better from our end. So I really want to appreciate everyone in the cordial way that this meeting went. I think the discussions were honest and robust and respectfully so. We allowed each other and appreciated one another. And I think for that, we really need to clap hands for one another for the way the meeting went. And to the question around the frequency, we are always willing, colleagues. I mean, I said it also that even in your own formations, whether at the provincial level or at a town level where you have numbers and you want to invite us in either some of your webinars, just give us a call. We will come either in person or join virtually. We are always willing because we understand that you are playing a very important role in the lives of the GEMS members. Remember, if you are happy servicing a GEMS member, that member will also be happy to belong to the scheme because they know that the interest of their health is taken care of, the interest of the service providers that are treating them are also being taken care of. So I've taken note of the colleagues that confirmed that they belong to InStop and even OTASA. So we will be reaching out to them from tomorrow to arrange those high-level discussions, and also towards the task team that is working on mental health to advise the scheme. And then we will also be, as I indicated earlier, from 1st of July, our provider liaison officers, some of them are also in this meeting today. So they've heard some of your concerns. So they will be coming to your rooms. And I must say that very clearly to everyone, they are not necessarily going to come to everyone because they are already committed elsewhere. But we have decided that from 1st of July, we are going to add your practices as well in terms of the engagements that they're doing, where they will be able to also assist in some of the challenges. You know, it's also nicer when you have a face-to-face person that you engage with, you know, whether it's your banker at the bank, you have that face that whenever you need something, you know, if I call this number, I'm going to speak to so-and-so, and my issues are going to be attended to and resolved. That's the approach that we want. We want you to also feel free that yes, emails do work, call centers do work, but there is also that human touch, that human element that you want to have. And that is where GEMS is coming in to address some of the challenges. So with that being said, colleagues, we will definitely look forward to having another webinar again, hopefully in maybe Q3 or early Q4, just to do a wrap up and to see whether have we made any changes and progress on some of the commitments. We've taken note of over 200 questions that you have asked in the chat today. So those questions, we're going to package them into a working document and give our inputs, and then we'll send them back to you, hopefully within the next 2 weeks, because we still have to meet with us again, as I mentioned, in this week as well. So you will receive all the indicated will also be shared on our provider app portal. You can always go back there to refresh your memory if you have missed something. And I believe the presentation of today will also be shared with some of the additional requests that other colleagues made on the data. So we'll look at them as well and then just do a little bit of refreshing, and then we'll distribute them accordingly. So with that being said, colleagues, I think I'm going to say thank you, everyone. Zandi, back to you, and looking forward to seeing you again, hopefully in person or when we come to the rooms as well to see you. And maybe some of you, I will come myself as well. I don't mind. Thank you, Zandi.
Thank you, Ramuelo, for those closing remarks. Colleagues, I think Ramuelo has covered everything that we need to cover in this wrap up. I also just want to thank you very much for your time and also for indulging us with extra time. Majority of the people that started with us in the session are still here, so we really do value your time. Thank you for the engagement. I also want to just share the same sentiments as Ramuelo in terms of just how we conducted the session. We really appreciate it, and we're here to help. And Ramuelo has really expressed, that in terms of our perspective. So thank you so much, colleagues. I want to wish you all a good evening. And from my side, it's 18:21, colleagues, and I would like to declare this session closed. Thank you so much. Have a good evening, colleagues. Please do take the survey as you exit. Thank you so much. I see all the claps and all the hearts. We appreciate it. Thank you for your time. Bye.